So, welcome everyone. In pursuit of patient safety, Cygnia Healthcare welcomes you to learn through discussing question and answers on certain domains of patient safety. I'm sure that the next few minutes, not few minutes, it's long minutes, you're going to spend with us to understand question and answer, which should help you in your practice. So, once again, a warm welcome. So, to become a safe nurse, that's why we are all here. And patient safety is the heart of our healthcare. I request everyone to mute your microphone. So, just give me 1 minute. I might just mute everyone. And please keep your video also off. Questions sent via chat box can be answered at the end of the session. Those who are watching this video after recording, these things are not relevant to you. So let's get into the first domain of why are we getting into this. WHO says that 4 in 10 patients are harmed in primary and outpatient healthcare. Even in acute healthcare, the numbers are not very different. I'm sure that all of you know that uh, there's a saying that the aeroplanes, all of us have taken flights. So when you get into a flight, you have 1 in 1 million chances that something can go wrong. But once we get admitted into a hospital, there is 1 in 25 chances of getting harmed. So we are going to discuss today 4 domains that how do we identify patients safely. These are around safe practices. How do we communicate safely, and how do we use transfusion safely and medication safety, alarm safety. Now, I will not say this is the beginning and end of all these domains, but I have put together all those questions which I have seen as a problem in my own experience. The first that we are going to look at is identify patients correctly every time. So when these, focus on identification of patient came through, there had been a lot of discussions. Many nurses will ask, why do I need to identify my patients every time? Because I know my patients very well. But we are aware that the patients can have similar names, patients can have similar numbers. So it is always worthwhile to have safe practices every time, each time that you are with your patient. So let me tell you how errors can happen. So it happened in ICU. The doctor came, and he during the rounds he told, let's put central line for this patient. I'll come back after rounds to put for this patient. So identifying patients before procedures, immediately before procedure, is one of the critical aspect, and it's very important inside the OT also. We understand that. So by the time the doctor went for rounds, what happened in the ICU was that because of certain reasons, they had to change the beds. Let's say a patient was in bed number 4, bed number 4 had to be transferred to bed number 5, and the 5 came to 4. So after rounds, when the doctor came, he went straight to bed number 4, and he said, okay sister, let's put the line. And unfortunately, the nurse assigned with bed number 4, she never asked the question that you had not discussed this during rounds. So she just started preparing for, putting the central line. Incidentally, luckily, the team leader who was around, she saw that this bed number 4 is getting prepared. So she came and asked, why are you preparing for the central line? And she said, the doctor told. Then the team leader told the doctor, I think, doctor, we are making a mistake. You had spoken about putting central line for bed number 5. So, what was wrong was here the doctor and the nurse, none of them bothered to identify the patient that who needs to have the central line. So, like this, I have many, many stories to say that please do not take all these things for granted. It does not help. So, question number 1. So, how are we going to do this? Once we are going through the questions, You can either put it in the chat box or you can write your answers in your notebook. And if it comes out correct, give yourself a thapki. Say, oh, well done. You know the answers. Very good. So, the question, the following instances, except for one, are occasions for mandatory patient identification. What it says is, in all these occasions, you must identify the patient each and every time. So, your options are here: medication administration, phlebotomy, not performing, hand hygiene before handover, surgical intervention, shift handover. Now, what is the wrong answer here? That's what we have to pick up. And I'm very sure that most of you have already picked it up. Not performing hand hygiene before handover. That has nothing to do with patient identification. Now, remember, the other options that every time you give medication to a patient, when you do any kind of procedures, phlebotomy is one of the procedures, any kind of surgery, during shift handover, all these are mandatory occasions where you have to identify the patient. Now, how do we identify the patient? That also will come up as a question in a moment. So, number two, the most common reasons for failure of ID bands in achieving 100% accuracy in patient identifications are, you are supposed to tick all that apply. Now, ID bands are there in all hospitals for all patients. Okay. So, though the ID bands are there, the failures they do happen. So, let's see what could be the common reasons: non standardization of ID bands, missing ID bands, incorrect or illegible information on the ID band, failure of healthcare provider to match the information on ID band with that of the medical records. Answer: all of them, because I'm sure the ID bands are not standardized across all hospitals. So some of the Western countries are now moving forward to standardize, because what happens when people move from hospital to hospital, they don't have to learn all over again what are the ID bands in this hospitals. For the time being, in Indian hospitals, wherever you go, you will learn what are the kind of ID bands and what are the information which are displayed on the ID band. Missing ID bands, I can tell you from my own experience, if I do a prevalence audit of ID bands in any hospital, I would definitely find few patients who don't have ID bands. And those patients, they do receive their medications also. So the question is then, what are my nurses doing? How did they give medicine to the patient without the ID band? Incorrect, illegible information. So one of the common reason for nurses to say the ID band, oh, it has gone off because when patient took bath, it became illegible. So if it is illegible, how can you identify the patient? Now, most common understanding is that ID band is the identifier. It is not the identifier. The information which is on the ID band is the identifier, the name and the UHID. UGRN number, UHID number, MR number, whatever number you call it, there are two identifiers which are there on there may be more information. What you use is the name and the UHID of the patient, and you are expected to match that information with the medical records. For example, I'm going to give medication, so I have my medication chart. So I must confirm. First, I should ask the patient, what's his name? And then, second, of course, you will match the information on the record with that of the ID band. That way, you are always following safe practices. So let's go to the next question. It is the prime responsibility of the healthcare provider to check the identity of the patient and match the correct dash with the correct dash. So select the two correct options. I'm going to wait here for, let's say, 5 seconds for you to give yourself your answer, and let's see whether you get it right. Write it in your notebook, not a problem. You can put it in the chat also. That is, only Ishita will be looking at it. I am not looking at that. All right. Okay. I hope you got the answer. Name, UHID, patient care, patient and order, none of the above. So which is going to match? Check the identity of the patient, match the correct name, UHID with the correct patient and order. So I think these are the two things that you need to match: the name and UHID of the patient, of the file with that of the patient, and the order, whatever order that you are going to carry. When you go to take sample also, you are going to make sure that you are matching the UHID and the name of the patient. So number 4, apart from identifying patients before medications and procedures, the following touch points also needs correct patient identification to prevent harm. So we already discussed some of the occasions where you mandatorily must identify the patient. Now there are also some touch points, that you have to ensure that you identify the patient mandatorily. Now tick all that apply, select all the correct answers. A, at the time of shift handover. B, at the time of assisting to toilet. C, at the time of transfer to another ward. D, at the time of transfer to another hospital. So I hope you already got your answer. So let's go ahead and see which is the correct answer. Oh, there's one more option. At the time of receiving critical test results and telephonic orders. So what all have you already ticked? If you have ticked all that, bingo. Please remember, these are very routine activities that we do, but it's very important when we hand over our patients, not only in the shift, when we transfer from ICU to ward to ICU, ward to OT, OT to the post-op area, pre-op area to the post. There are many transition points, transfer from one hospital to another hospital. Very important that we identify the patient and we hand over the right report and the right records. And also, when you are receiving the critical test results and telephonic orders, you have to identify the patient. When you are receiving the result, am I getting the result for the right patient with the right UHID number? Telephonic orders. So there are many such practices. They are not rocket science, but it has to be consistently practiced for a nurse to be safe. I always used to tell my nurses that the SOPs or the protocols are written down not to harm the nurses. It is to ensure the nurses practice safely so that the patients are also safe. So when we don't practice, some error happens, then the next is that you are also explaining why it happened. Why to get into that kind of a problem? Keep smiling. Do the right practices and you are going to be safe and your patient is going to be safe. Next question. When identifying patient by matching the information on ID band with that of the medical records, it is important to involve conscious patient by asking him to state his or her name. The answer is not very complicated. It is either yes, no, or you are not saying, oh, it's okay, ID band and medical record information is matching, so why should I? So what's your answer? I'm sure you must have got the right one. It is yes. So you always involve the patient to make sure that what are you doing? You cannot go and catch his hand or her and then say, I will do this. So there is a process. So there is a process that you have to involve the patient to state his or her name. Okay. Now let's go to the next one. Number 6, when is the ideal time to label specimens and blood samples to ensure correct patient to correct sample? Now, sample errors are very common errors in almost all hospitals. Every hospital is struggling to reduce that, error, because if you have errors, you will have wrong reports or you have to prick the patient again. There are many other things which are involved when one sample is wrong. So now again, nurses are the ones who collect most of the time the samples. So when do you label? Now I am talking about the right practice that is required. So there may be hospitals where they are using barcode or label is getting printed out before collecting the sample. Can I label all the vacutainers before I collect the sample is the question. In the presence of the patient by involving the patient after collecting the sample. It can be done anytime during sample collection. Answer: in the presence of the patient by involving the patient after collecting the sample. So that way you are safe by telling the patient, okay, Thankam, oh, the Miss Thankam Gomez, okay, I've taken your sample. You put it at the bedside after collecting the sample at the bedside. Never bring the sample to the nursing station to put the labels. So when we do root cause analysis of such errors, you will find that this is one of the practice that can go wrong. So always remember, you will label the specimens at the bedside by involving the patient wherever possible. Now, let me tell you, recently I got sample collection done at home. From SRL, someone came to collect my sample, but they followed the right procedure, though they were collecting two, my mother's and my sample. But he made sure that first he collected my mother's, then he made sure the spelling, everything of my mother is correct. He labeled everything, put it into a bag, and then he collected my sample. He could have collected both hours and decided to label. Then what will happen? There can be error of mixing up of the samples. So this is very important to keep in mind, that where do you label your specimens and samples. Now, is it important to identify nonverbal and unconscious patients? What will be your answer? And I'm very sure that your answer will be correct. By this time, you are very much aware. There is no two ways about it. Yes, you have to identify the nonverbal unconscious patient. How can you do that? One will be, if the attendant is there, you are going to speak to the attendant and do the same procedure. And of course, there is a ID band on the patient, so you need to confirm that you have the right order of with the right name and UHID. So you have to have the same practice. Next, when using electronic information system that many hospitals have, HIS, HIMS, whatever name you call it, accessing patient information, the safest way to identify a patient will be by. Now, I have seen errors happening because there is always patients of similar name or same name in the same hospital. It is always a possibility. So there is something called LASA, look-alike, sound-alike drugs. I call it as SASA. SASA means sound alike and spell alike patient. That means there are two patients who sound alike and who could be also spell alike. Like Kiranjeet. Kiranjeet can be spelled with an I or with a double E. Thankam can be spelled with a K and with a G, but we do the same pronunciation. So it can, lot of errors can happen. So when you enter in the system, what should be the best way to do it? By typing in the UHID, after UHID double checking the patient's name, by typing in room number and bed number, A and B, what is your answer? Should it be only A, just put UHID, or should I also check the patient's name, or just put my room number and I'm sure that it will come up? What is your answer? Or any of them will work out? Let's see. Is A and B. It is always safest to make a system by which you have to type in the UHID and then again match the patient name. There also two identifiers need to be followed. So what happens is that when you have SASA patients, that means sound alike, spell alike patient, if you put the name first, there is a chance that you might get the wrong. Follow the right practices. Okay, let's look at the next question. Knowing that in India, most patients will not remember their UHID number, I'm sure, because I don't remember my UHID number in hospitals where I'm registered. The initial identification of the patient at the time of admission is critical. So imagine that you have got admitted into a hospital and the nurse or the front office, whatever is the protocol, you're going to put the ID band for the first time. Now, this is something that I stumbled upon when I was in hospital, that this process was not being followed correctly. So there was a huge risk that the wrong ID band can get into the patient. Have I experienced that the patients had wrong ID bands in my life as a nurse? Yes, I have seen it, because usually that mistake happens either the first ID band time that you are putting, or when you are replacing the ID band because the ID band got soiled or whatever it is. So you could have may put the wrong ID band because you do not follow the safe practice. And once the wrong ID band goes in, anything can go wrong with that patient. So, how do you check the initial identification at the time of admission? Check name and date of birth and apply the ID band. So, is that okay? Getting the patient or the family to confirm all details on the admission sheet. Just read out the details to patient to confirm any of the above. So what will be the best practice to do when you are admitting and you are going to put the first time ID band? That means you have a admission paper, so you can, if they can read, the best thing is give it to them and say that please confirm that all these details are yours. Because what happens, you have the name, you have the father's name or husband's name, the address, the number, contact number, so everything they can confirm. This is to make sure if there are two Thankams, we just don't go by Thankam and give the wrong UHID to me. So it is better that you verify everything in the admission sheet and then put your first time ID band. Once it is applied, it is also important to educate the patient. What is this, ID band? Why is the ID band here? If you educate them and you tell them it is for your safety, that every time when someone is going to give you medication or they are going to do any procedure for you, they are supposed to match the information of your medical records, the name and UHID, with that of your ID band. And also, you should be asked to identify yourself. So, if we can teach this much to our patients, I'm sure the practices will start to improve. Next question. When involving Mr. Sharma in the identifying process, which question is the safest? So you have a patient by the name of Mr. Sharma. You are going to identify the patient. Now, which is the safest one to do? Are you Mr. Sharma? Kindly state your full name. Oh, I repeated the question. Are you Mr. Sharma? Sorry about that. Or any of the above. So, which one do you think is the most appropriate answer? I would uh, definitely want you to write down the answer in your sheet.
I see the still
No
again.
need to speak up. No need to speak up. The best thing is to do kindly state your full name. This is what is required to be done the correct way of identifying. You don't prompt a person. If the person is not, paying attention, they might just say, yeah, Mr. Sharma is not a full name. It is only half name. So patient has to state his full name. So I have to say Thankam Gomez, not just say Thankam, because there may be multiple Thankams. Even there could be two Thankam Gomez also. Correct identification of newborn is critical when handing over the baby for breastfeed. Yes, no, not sure. I'm sure all of you got the right answer here. It's not rocket science. This misidentification of newborns in nursery, giving over for breastfeed, handing over the babies to when they are discharged, all these are very critical mistakes that can happen. So, let me tell you, if you follow the safe practices each and every time, you are always going to be safe. Which of the following statement about patient identification is correct to prevent harm? Critical among infants and neonates, critical among unconscious patients, regardless of age and conscious level, always match the information on the ID band with that of the medical record. Two identifiers. Pay special attention to vulnerable group. So what will be the best answer here? Is very simple, very basic. All of the above? I would say it doesn't matter. Who is the patient? What is the patient age? What is the age? What is the conscious level? Just always practice matching the name and UHID of your patient with that of because medical record is what you are using to carry out orders, to give the medications, do procedures, send the patient somewhere, MRI, CT scan, ultrasound. So it doesn't matter. So if you follow the same safe practice each and every time, you can definitely avoid this mistake, right? What are the common barriers of correct identification of patient? So these are the common, mostly the barriers are here. Absence of ID band, information on ID band not clear, healthcare provider assumes that they know the patient, healthcare providers do not carry medical records to the bedside of the patient, healthcare providers lack of knowledge of the potential risk of not identifying the patient each time and every time. Answers are all of it. If there is no ID band and the healthcare provider does not stop and say there is no ID band, I cannot proceed with the procedure, mistake can happen. You have the ID band, but it is not clear, but you go ahead and do the procedure. Again, it is a unsafe practice. Very common thing. Many nurses will say, I am looking after this patient for last so many days. I know the patient very well. Don't get complacent. It is always better to follow the safe practices. Healthcare providers do not carry medical records to the bedside of the patient. This is another problem. Maybe the file is with the doctor, maybe the file is in the discharge department. I wonder, how will you give the medication? So it is very important that nurses should insist on having the medication administration record with you when you are going to give the medications. Healthcare providers' lack of knowledge of the potential risk of not identifying the patient each time and every time. Yes, this is an attitudinal problem because we think that it is not important. We tend to believe that that error can happen with them, with that patient in that hospital, not with me. Believe me, my friends, it does not take much time. Once the error is executed, it's very difficult to reverse it. And it is definitely a problem. It is going to be a emotional burden on all of you if even by mistake, if you do a mistake. We all are humans, we all can make a mistake. That is why it is important that we have to be absolutely focused on doing the safe practices. And yes, I believe in saying a prayer every time before I go for duty to my hospital to help me not to make a mistake by mistake. This used to be my prayer. So we finished with the segment on identifying patients. So we are going to get into communicate safely. Now, communication itself is a very large domain, and you can have workshops of 1 or 2 days around it. So, we are going to ask a few questions so that you again pick up some safe practices from here. Healthcare communication is very critical because there is a whole lot of people communicating with each other, and this is probably the most important fulcrum on which the entire healthcare is revolving. So you can see here on this side the root causes of sentinel events, which is analyzed. Communication is right on top. So that means poor communication could mean inaccurate communication, no communication, miscommunication. Now, we all work with each other by communicating either verbally or by writing. So, very large domain. So, I am going to just showcase, ask some questions. Now, you people must be wondering that why these questions. These questions come from my two activities of Patient Safety Day in 2021 and 2020. 2020 quiz to nurses from different hospitals. 2021, I gave slightly, easier quiz to nursing students. In both the quiz, I mean, we had more than 500, nurses taking the quiz and the same number for the students also. We did not have high percentage of, pass. The pass marks that I have kept was 80 percentage, which kind of, indicated to me there is so much that needs to be discussed. And I mean, probably this one activity is not enough. Everybody needs to talk about it, everybody needs to remind each other, and there is repeated training that needs to happen. So gaps in communication can lead all the following except breakdown in continuity of care, development of hospital acquired infections,
Mm.
appropriate treatment, potential harm to patient. Oh, sorry, I shouldn't have clicked that. Okay. Now, gaps in communication majorly will lead to a breakdown in continuity of care or inappropriate treatment or potential harm to patient. There are more effects of, gaps in communication that can happen. Development of HII is least connected to a gap in communication. Okay. So, next one. Let's go to the next one. Handover communication on patient specific processes include the following. Tick all that apply. Handover communication is one of the touch point which is told as a critical touch point where the communication needs to be complete, accurate, so that the continuity of care maintains. So, what are the kind of handover that you expect in a hospital? From one caregiver to the other, from one team of caregivers to the next, from caregivers to family, from one type of healthcare to another. So, what do you think? Which all should apply, or it's only A, or it's only B, or C, or it's only D, or from one healthcare organization to home? Please mute yourself. Please keep yourself muted.
एकदम आपण B20 चालू केलं
I am trying to see.
हॉस्पिटलमध्ये
Ma'am, I don't know who is speaking. I'm trying to get.
So, friends, what would be your answer here? If you selected all of it, bingo, correct. From one caregiver to the other, from a nurse to a nurse, doctor to a nurse, doctor to a doctor, all of them are important. Nurse to a technician, nurse to a GDA, it doesn't matter. One team of caregivers to the next. So maybe in OT, when people are changing, the entire team is changing, you have to do that. Now, when caregivers to family, when you are discharging the patient, you are actually handing over the care of the patient to patient himself or to the family, one type of healthcare to another. That means you are going from maybe a hospital to another hospital. Type means, okay, you had been in acute care, then you are going to a transition care. There also you have to give handover, and one healthcare organization to home, that is also important. So anytime when there is a changeover of people or setup, you have to ensure that the correct process, correct communication is followed. Inside the hospital, transfers are very common from OT to the pre-op to OT to post-op to the ward to ICU to OT. There are so many transition points, so everywhere the communication is very important. One of the common root cause of patient harm due to communication error is lack of practice in daily activities due to failure in leadership focus, not placing significant emphasis on involving patient and families, all of the above. So maybe you would like to pick what is the the root cause. So I would always place the root cause, maybe the nurses are practicing, the leadership is definitely focused, SOPs are written down, but I would say that most of the time the communication errors can be really prevented if you involve patients and families, because they will support you to make sure that communication is complete. Let's say that you are giving shift handover, and both the nurses are at the bedside, and you are telling the patient that I am leaving for the day, and now Bessie is going to look after the patient, and we are going to give handover. You please feel free to ask question and participate in the handover. So while you are giving handover, maybe the patient will say, sister, but doctor told me that I am for ultrasound tomorrow. So she'll say, oh, I'm so sorry, so let me check the file. There seems to be no order, sir. Let me check with the doctor. So then you call up the doctor. You are again communicating, right? The doctor will say, oh, yeah, I'm so sorry, sister. I forgot to write it down. So, okay, I'll get my resident to order. The patient is for ultrasound. Now, if this conversation did not happen in front of the patient, you will not know. Only you will not know at least till the next day. During rounds, the doctor will say, ultrasound. Then nurses will say it's not done because it's not written. Patient will say, yes, doctor told yesterday. So there is unnecessary friction between the team members, which can be easily avoided. So involve the patient and families. This is very, very important. Language barrier due to nurses moving away from their motherland to other states and countries increases the risk of harm due to communication errors. I put this question here because this is a very common mistake that can happen, because if we don't know the language, we tend to communicate less because we are not confident of that language. So we will communicate bare minimum. When that bare minimum happens, there can be gaps in our communication that can lead to errors. I have enough and more stories around that. So I'm sure theoretically everyone knows the answer. What should be the answer? Obviously, it is yes. So recently, I've seen nurses who are getting ready to go to Finland. They are getting trained in Finnish language. Why are they getting trained before even they reach? The country is insisting that you should have certain competency level. Nurses who go to UK, they need to have certain competency level, IELTS or OET. Why do they insist on that? So that you are able to communicate with patients and families and other team members, right? So it is a big yes for that. Now, few of the standardized verbal communication framework for safer communication includes following except one. Now, there are evidence-based communication tools available that one can learn, so that communication, if you look at the domain, is very large. So it is not about learning the theory of communication, that there is a sender, there is a receiver, and there is a decoding that is happening in between. That is all gyan, but gyan does not help us into practice. So what is that we should be practicing? S bar, is bar, read back, teach back, shift handover. So we are asking for one that is an exception. Rest all are communication tools. I'm sure that many of you have got the answer correct. Shift handover is not a communication tool. It is actually a occasion for correct communication, but it is not a tool. S bar is actually situation, background, assessment, request or recommendation. When you add an I to it, it is identification and introducing self. So that's why all these tools are separate, um, workshops where you really understand how to use it. Read back and teach back. So we will be discussing on them a little bit in detail in the further questions. Question number 5. Dash is the communication tool used when receiving urgent telephonic order or receiving critical test results. Now, those nurses who are here, maybe you would like to answer that to yourself, because you all have learned this, because this is a standard practice, in all accredited hospitals. So maybe you could have written down. Now, students, you might have heard about it or you might not have, but today you are definitely learning. Bar, read back, check back, call back. So, what should be the answer? Maybe you would like to answer yourself, and maybe when you think about it, maybe you'll come to the right answer also. What should be the right answer, or can that any of the above? Can it be any of the above? So, this is we are talking about when you are receiving a telephonic order, you're getting an order from a doctor. Telephonic orders are routinely not allowed. Okay, this is only allowed in emergency situations. As a nurse, basic principle should be, if you are getting a telephonic order from a doctor, if you have another junior doctor there, give the phone to that doctor. That's the most safest thing. Give it to him. Let him or her take the order. But if you are the only one who need to receive, then you follow a certain communication process. The same process you also do for receiving critical test results. Now, what will be the answer? Read back. Now, I'm going to spend 2 minutes explaining to you what is read back. Read back means I have got something written and I am going to read back from there, right? It is not about repeating back. So, if a doctor is giving me an order to give a patient Lasix 40 milligram, so if the doctor is calling, first of all, I will pick up the phone, I will follow my regular telephonic etiquette, etc. I will tell the doctor, let me get the file. Identify the patient by name and UHID, and each hospital will have their protocol where these orders are to be written. So, if the doctor says, sister, give the patient tab Lasix 40 milligram stat. So, I will have to first write, identify, sir, this is the patient and this is the UHID. I write it down with the date and time. I write tab Lasix 40 milligram stat oral, okay, PO. I'll say, sir, let me repeat the order that you have given me. You have given the order for Mr. Balram, UHID so and so, and it is tablet Lasix 40 milligrams stat oral. Is that correct? Doctor will say yes. And then you can sign it off as per the protocol. The same thing happens when you get critical results from the lab also. This is called read back. So read back is not that telling the doctor, hello doctor, yes, you told me that to give Lasix 40. No, that is simply you're repeating back. It's not a safe practice, because you might forget, you might get busy. So it is better to write it down at the right in the right file, and then read back. Next, the communication framework that is used in emergencies to avoid errors. Now, when you have an emergency like you have a code blue, or there is, patient has come into the ER, he's, very sick, or the patient is just come to ICU, there can be any kind of emergency. So, what is the communication framework that you will use? Again, S bar, read back, call out, or any of the above. Now, as I discuss different tools, I hope you are appreciating the different tools are meant for different occasions. So, what would be the answer here? Call out. So, those who understand being in hospital when there is an emergency, not enough time for the doctors to write down orders. They are telling orders and we are carrying it out. Now, call out is one way of telling things loudly so that everybody is aware what is being done. So, if you take the example of code blue, let's say the doctor ordered for sister adrenaline 1 milligram IV. So the nurse, those who have attended the ACLS, training, you would appreciate that this is call out is practiced and trained in that code, right? In ACLS. So the nurse says 1 milligram adrenaline loaded. Doctor says, please give it. The nurse says 1 milligram adrenaline intravenous given saline flushed, arms raised. I mean, it's like a drill. Okay. So you should not feel shy about it. I mean, it is quite all right. So we used to practice this in ICU. When I was working in the ICU, we will get new admissions sometimes from emergency RTA. So you have to put line, you have to, lines must be there. We have to connect the monitor, we have to take the vital signs, start the ventilator, start, connect this, connect that, do ECG. There are many things that are being done. So there are 4 or 5 people working on the patient. So to avoid anyone asking what is the vital signs, have you done this, have you done that? So we used to have assignment for the nurses by saying that who will take care of the ABCD. That means who takes care of the airway, who takes care airway and breathing, and who takes care of the circulation. Circulation will mean connecting monitor. So we have given certain roles. So the nurses will actually you know call out and say, okay, monitor attached shows sinus tachycardia, saturation of this much, and if there is an arterial line, connect that. Say this is the BP, or someone takes the BP, and someone else says, okay, 18 gauge cannula in, samples are already collected. Someone says, okay, I've called the X-ray. So this is like a big drama that happens. But this drama is essential to ensure that we don't make any mistakes. Sorry, same things will happen inside the OT also, to make sure that there are no surgical errors. So let's go to next one. The communication framework that nurses use when informing the doctor on patient's condition. Now, when I was in the hospital, when I was in hospital, many times the doctors used to complain, "Ki, ma'am, please teach the nurses how to inform the doctor, when they have to inform something to the doctor." Sorry. So every time they will say that, we have to ask 10 questions before we come to the actual need. What does this nurse needs? So let me give an example. The nurse is calling the doctor to inform about the blood sugar, and she wants to know how much insulin to be given, let's say. So she calls the doctor and she says, hello, Dr. Verma. This is Thankam from so and so ward. This is regarding your patient in room 201. His blood sugar is, 134. So you'll say, 201, sister, what's the name of the patient? Oh, his name is Mr. Verma. Okay. What was the last blood sugar? Oh, just a second. Then she will run for the file. Then she will do like this and say, oh, the last blood sugar was 120. Okay. What was his last insulin, sister? Oh, again. So it's going back and forth. The nurse could easily summarize everything by using a communication framework. What is that framework? S bar, read back, call out, or any of the above again? It is S bar. I would always like to add, S bar is internationally known, but I would always add an I to it. That means introduction and identification of the patient. Then talking about the situation of the patient. What is the background, and then what is the current assessment, and what do you want, recommendation or request. So if you follow this pattern, your information can be complete, concise, and accurate. Concise means short, not taking too much of time. So that is your S bar. Number 8, what are the potential pitfalls of communication during handover between shifts or in between units? So what are the problems that can happen with hand communication? Not doing it in person, might not include all information, not performing hand hygiene before handover, information may be misunderstood, all except C. What do you think is the correct answer? I'm going to give you 5 seconds when I am getting myself a little bit of water. So, friends, if you have one more option, B and C. So, what is your answer? All except C. So, when you are going to give handover, one, you are not doing it in person. That means you are not at the bedside of the patient, and maybe sometimes it happens, one nurse will tell the other nurse, this is the patient, just hand over and come back. So there can be high chances of missing out information, and then might not include all information. It is incomplete, and the information may be misunderstood. So it is very important during shift handover to ensure that when you're giving to the other nurse, ask them, have they got all the information they need to care for the patient? Do they have any question? It's very safe practice. When I was the bedside nurse, I always used to ask my own incoming nurse. I'll say, okay, I hope you are happy. Do you have any questions? Have any doubt? Can I go? That was the last question that I will be asking my counterpart. This is to ensure that she has received or he has received everything that needed to continue the care. It's a safe practice to have. So that kind of completes our communication safety. Now we come to medication safety. So you, in the beginning, that the video that you saw, it kind of emphasized, that how many medication errors are happening across the world. And you have data from US, but we do not have data from India. So I really cannot tell you what is the quantum of problem that is happening in our hospitals. So this is 5 moments of medication safety from WHO. This is actually safety moments created for the public, but I think even for nurses, it's a very good starting point. Let's go one by one. Starting a medication. As a nurse, I must know what is the medication my patient is getting and for what purpose. Now, it is impossible for one nurse to learn everything in the world about all the medication. So, where can I start? Just simply asking the doctor, what am I supposed to observe? So that you get a very quick, answer. I'm sure the doctor who orders the medicine, he knows about the medicine. But have the courage to ask the question. It does not take much time. When I was a bedside nurse, I learned maximum by asking such questions. Then taking medication, because let's twist it and say giving medication. At the time of giving, follow your 5 hour, 6 hour, up to 10 hour it is there. But I would always say at least if you follow your initial 5 to 6 hours, you are always safe. Adding medication. So when doctors are adding medications and removing medication, please be aware why a certain medication is being added, why a certain medication is being discontinued. You actually become a very smart nurse if you just follow the doctors and you ask the doctor one question. Okay, sir, why did you discontinue this and put this one? He might tell you, sister, this is nephrotoxic. Look at his urea is going up, so I wanted to change. It's a permanent knowledge for you. Next time you will know, okay, this drug is nephrotoxic, so I need to watch out for the patient's kidney function. Reviewing medication. So always very important that you know your medication at the time of shift handover itself. It's very important to go through the list of medication so that you are aware that you know what medication my patient is getting, why a particular medication is being stopped, or why a particular medication must be stopped. Now this is a very very critical component of nursing activities. I'm sure you will agree that nurses are the people who give almost all the medications across the hospital, barring in few areas where the medication could be given by someone else. Otherwise, It is always the nurses. When a patient receives a wrong medication, how many errors are being made? Is it one, two, three? How many errors are being made? This time I would like to look at the chat box and see the answer. What do you think? How many errors are being made when a patient gets a wrong medication? Can I get some answers? I'm just watching the chat box now. One, two, one. No, this is not the current answer. Okay, I'm not getting any answer. Three. Okay, three. That's a nice number. Okay. I'm glad that nobody wrote one. Two mistakes are happening when you're giving wrong medication, wrong medicine, wrong patient. That two medication, two errors are anyway happening in any which way you look at it. So it is very important to remember that we don't want to make this mistake. Medication errors can commonly occur in the following phases of medication process. Tick all that apply. Is it prescribing, transcribing, dispensing, administering, purchasing? Where do you think are the maximum errors that happen in medication error? I'm sure you got the answer right, because this one everybody will get it right. The purchasing, the medication error cannot reach the patient, but through prescription, by transcribing, dispensing, administering, these are all learned to lead to medication error. Now I'll give one small tip around transcribing. So please watch out that the current practice is that the doctor should be writing directly into the medication record. It is not that doctor writes in one place and the nurse then transcribes it to another place. So if you remove that one transcription completely out of that process, you are reducing the error possibility, because if you start transcribing after the prescription, then it becomes a chance for more error, that you could be writing wrong doses, wrong route. I have seen enough of this happen. So I would always champion for doctors writing directly into the medication record. So who can be the last line of defense from medication error from reaching the patient? Can be the last line of defense. A doctor, a nurse, or a RMO. I'm sure this will not take much time from the nurses, because we are the last line of defense for sure. Others do have a role, but then they are not the last one standing beside the patient. Following are some of the high risk medications: vasopressors, insulin, heparin, opioids, diuretics, which are some of the high risk medications. There are high risk, medium risk, and low risk medications are there. So which are the high risk medication? If you have got it right, okay, let's see. So except diuretics is a low risk medication. Otherwise, vasopressors, insulin, heparin, opioids. So it's a wise idea, wise advice to all the nurses and all the nursing students that we must learn about our high risk medication without fail. It doesn't matter where we are working. We must learn about them. Then there is medium risk, all the cardiovascular drugs, the diuretics, all this, and they also have other complications. So at least when it comes to medication safety, one must know about the high risk medications. Now the doctor says, this one I would like to have answer from in the chat box. The doctor order says tablet digoxin 0.125 milligram PO once a day. Pharmacy has sent tablet strength of 0.5 milligram tablet. How many tablets will you administer? I am looking at the chat box to see how many tablets will you. I'm not giving the option, so let me see if somebody can put an answer there. by doing your calculations? Okay, thank you, Hannah. I saw the answer there, 1/4. 1/4. Okay. Nice to see some answers coming very quickly. So why did I put this question here? You all will be surprised that I had a nurse who was going to give 5 tablets. The tablet that came was 0.5 milligram. The order was 0.125. I don't know from where she thought that she has to give 5 tablets. Fortunately, she did not give because the pharmacy did not send that many tablets. So she came to us to say that pharmacy sent the wrong medication because they have not given so many tablets. And we could stop. And let me tell you, by my experience of, interviewing thousands and thousands of nurses, drug calculation is the weakest among our nurses. And recently I have had a proof for that, because there were a set of nurses who were getting interviewed to go to Finland. Now that company who was interviewing has come back and said that there is a problem with drug calculation with these nurses because they were not able to get it. The questions that were asked, I would say they were not very, very simple, but they are right questions to be asked. Answer was not correct for even the smartest of nurses. So now they were asking, can we get BSc nurses who has got maths background? Now, can you imagine? I mean, these are all real stories, my dear friends. So I'm happy to see that many of you are able to answer, but if you are not, please brush up your basic nursing mathematics. This is very, very important. Okay, next one is about IV infusion. So there are drug calculation, there are IV infusion. The doctor has ordered for 1500 ml of saline over 16 hours. How many drops per minute will you adjust with the drip set of drop factor 20 drops per minute? So I'm not going to give you options. So let me see whether you can do some mathematics and get the right answer. You have to know how to calculate. You have to know the formula so that you are able to see that you get the right answer. So your time starts now. Let's see whether I can get it in 30 seconds or 1 minute, the correct answer. Yes, friends. Okay. 31 drops, 24 drops, 31 per minute. Now I put here 131 per minute, 97 ml per hour, 100 per hour. Now it's very important what is the order. The question is about drops. So answer will also be in drops only. Now, very important for you to notice that, when you are giving an answer, always remember not to say this because there is no specification. 31 drops per minute. So how will you calculate? I need to give 1500 ml of saline over 16 hours. So answer, I have to get it in minutes. So I have to multiply that by 60. And here is the drop factor. So now it's not rocket science. You can use this for any kind of IV infusion. It becomes very easy. So this is what I need to give. So if I go this way, I come here 3. So that is about 31 point something will come. So 31 drops per minute. I took a minute to explain that for everyone to do a very quick review of it. Yeah. 31 drops per minute. Now, number 7, Nurse Bixie is about to administer 10 a.m. medications, but the patient file is in doctor's office for discharge summary. How can Bixie administer the due medications? Note the medicines before sending the file. Write down the medicines in a piece of paper. Keep the medication administration chart before sending the file. Nurse Bixie has been looking after the patient for many days, so she knows the patient's medicines thoroughly. So, what do you think is the best option here? Can I see it in the chat box? So, you have learned some of it, so I'm just trying to see. Very happy to see some correct answers coming up. So the correct practice will be C, not A, my dear friends. I know that you do have challenges, that medication chart is not left behind, but for safe practices, you must always insist that I need to have my medication administration chart. It's very important that you should insist that I should get the MAR for me to give the medication. Otherwise, you must have an option to have the original chart or a copy of it with you. You cannot write down, you cannot note down, because it is actually increasing the risk of medication error. So I'm very happy to see a lot of people got the flavor of this discussion today. Okay. So next one, all patients receiving vasoactive drugs are at risk of orthopedic hypotension, hypovolemic hypotension, orthostatic hypotension, all of the above. So I'm watching the chat box. What is your answer? What is your answer? Can some people type it into the chat box? So there's a little bit of confusion between hypovolemic and orthostatic. Now, very important, vasoactive drugs are the ones that act on vessels. So they are more prone to have orthostatic hypotension. Hypovolemia is when you actually lose the volume. So here there is no risk of losing the volume, but it is more about vasoactive. The vessels are either getting dilated or constricted based on whatever is the medicine. They are prone to have orthostatic hypotension, and they are linked to many other problems that you could face in the hospital. Okay, next one. What are the common gaps in identifying patients correctly before administration of medication? Assuming that the patient is very well known to the nurse, failing to match the name and UHID of the patient medication chart with that of patient ID band, and involving the patient, increased workload, too many verbal orders, A and B. What will be your best answer now? Now we have discussed enough around this. I'm assuming that by this time, many of you know the answers. Okay. See, too many verbal orders should not be a choice at all, because that is up to the administration to make sure that there are not too many verbal orders. The answer will be A and B. Okay, friends, are you able to hear me? Hello, Ishta?
Yes, ma'am, can hear you. I just wrote it that there was some network issue from your end.
Yeah, I just kind of lost the connectivity for a moment. Thank you for holding on. Just give me 1 second. So we were just discussing that, from individual nurse's point of view, it is assuming that the patient is very well known to the nurse or failing to match the name and UHID of the medication chart with that of the patient. ID band and involving the patient are the common reasons for medication errors. Let's see now, when is the ideal time to document the medication administration? Another reason for errors that can happen. At the end of the shift, just before medication administration, soon after administration at the patient's bedside, soon after administration at the nurse's station, C and D. So, what will be your right answer here? Some people are choosing B. Hmm. The most safest practice is soon after administration at the patient's bedside, never before administration, never later. This is one practice that you must follow. It doesn't matter rain, unless the patient is arresting in front of you, that you have to drop everything. Please document it at the bedside. I will tell you that it will stand you good forever. It will also give you a chance to relook at what you just did. In case you made a mistake, you are able to inform the right person, or maybe if you missed something, you can take care of that. So it actually helps you to prevent any medication error. This is from my personal practice. Okay. Next one, following is a good practice for any nurse to prevent harm from medication administration. Sorry. Talking about self double check during the entire process of preparation and administration. Always get seniors to double check. Ask the patient to double check. Leave the meds with patient or family. So, what do you think should be done by individual nurse? I'm a little interested to look at the answers now, or any of the above. Very good. I am getting some correct answers, A. Very good. If you are a nursing student, obviously, and if you will only be doing this under supervision, so you will always get seniors. Otherwise, once you become a practicing nurse, you don't get seniors to double check for all your medication. High risk medications are to be double checked. Otherwise, always follow this practice of self double checking. It's very important before you take out the medication, before you open the medication. We learned all this in nursing, but somewhere when we actually start practicing nursing, we forget that basics that we have learned. If you follow that, you will always remain safe. This is very important because medications, once you made the error, you cannot go and take it back from the patient. It becomes so difficult, and it's very painful for you also if it has harmed the patient. What is the safe practice to ensure that patients receive the right drugs throughout the continuum of care? That means wherever they are inside the healthcare system, they are always getting the right medicine from the time of admission to the time of discharge and even at home. Refer to home medicines, verify allergy, medication reconciliation, double checking. What is that one should be following? So, if you have not learned this word before, this is called medication reconciliation. This is a process that is recommended to ensure patient gets the right medicine at any point of time. So, at the time of admission, you will see what medication patient is taking at home. Throughout the stay, you will make sure it is the right medicine for him, for his history and all that stuff. And when they go home, you are putting the patient back on the right medication. So let me tell you a story about this. Patient got admitted for TKR. Patient is a known case of coronary artery disease on beta blocker. Now for surgery, they held the beta blocker. They said hold beta blocker for 48 hours. So what happened? It was written hold, and the entire team just forgot that they had to consider restarting the beta blocker. Unfortunately, the patient had a episode of angina. Patient had chest pain, ECG with changes. That's the time the doctors also realized, oh, we forgot to put back the beta blocker. So fortunately, the patient did not have a heart attack, myocardial infarction, but it could have progressed to a myocardial infarction very easily. So medication reconciliation. Now, what is the role of nurses? Because we are the ones giving the medications. We know that something is written on the chart. Hold. We should have immediately prompt. That's why we are called the last line of defense. If the nurse asked one question, sir, you have not started the beta blocker, it was held for surgery. Now, the nurse should know also it is held for surgery with a purpose, right? And then after that, it needs to be restarted. Why is the beta blocker? What is beta blocker? So all the story is connected to each other. So it is very important. Remember this medication reconciliation. Now, which are some of the drugs that should not be crushed and given via NGT? It's a very common problem that I have seen across the board everywhere. Especially in the ICU when patients are on NGT feed. Extended release tablets, enteric-coated tablets, sublingual tablets, delayed release tablets, all of the above. What could be your answer? Happy to see Hannah. Hannah seems to be the first finger here. Yeah. Okay. It is E, all of the above. The word could be different for different kind of extended release, enteric coated, sublingual, of course, that it has to go under the tongue, so you cannot give it to the NGT. But A, B, and D, all of them are sustained release one. They are all called sustained released, so they have to reach certain part of the intestine for it to work the way it is intended to work. So you cannot crush and give it to them, right? So this needs to be kept in mind so that you don't make it a mistake. Now, to prevent fatal errors by giving oral medication via IV route, the following safe practice would be the best. Now, this is because there is an error area called wrong tube connections. It can happen. Mostly, it can happen when the medications are, to be given by NGT. So, label the syringe as oral medication. Oral syringes must be designed so that it should not be possible to connect to an IV portal, because this is when you mix up the medicine in a syringe and you are giving it to the patient by the NG tube. Use ounce glass to prepare the oral medication, any of the above. Now, it may or may not be happening in all our hospitals, but the best, safest way is always to make sure the design of the syringe. In our Indian setting, yes, you can label the syringe as oral medication, but the most safest one to use is oral syringes should be manufactured separately as oral, so it can only connect to the NG tube, not to a IV tube. Now, we have heard stories where the NG feeds, a continuous NG feed was connected to the central line, and the patient even lost her life. So these kind of sentinel events have happened. So it is very important that we should be aware, and as nurses we can ask for design changes. It's very important. If you think that this is for somebody else to think about it, it is not necessary. It can come from nurses also. Now, you have a match the following here. Let's see. Mrs. Menon, a 68-year-old woman, came to ER with abdominal pain and dark stools. Please remember the history. The following few questions are related to this history. She is a known case of CAD on aspirin, simvastatin, and enalapril atenolol. 3 weeks ago, she had consulted doctor in OPD for muscular pain and she was put on tablet diclofenac for 7 days and then returned to see the doctor. The following questions are related to the above case study. Match the following. So you have to match the medicine with the action. Diclofenac, aspirin, enalapril, atenolol, simvastatin, oh, I have got two diclofenac here. Sorry about that. Okay, let's. I am going to show the answers. Aspirin, antiplatelet, enalapril, AC inhibitor, simvastatin, atenolol, beta blocker, simvastatin, lipid lowering, diclofenac, NSAID. Now it's very easy to remember some tips. All the prills are AC inhibitor. When they end up with pril, prolol, lols are usually beta blockers. So it's easy to all the statins are all lipid lowering. Very easy to understand. Keep in mind that diclofenac is a non-steroidal anti-inflammatory. Along with aspirin can become dangerous. Okay, so now let's see. Mrs. Menon was advised to discontinue and hold aspirin for 3 days. She was started on a proton pump inhibitor. Which drugs below are of this category? Ranitidine, ramiprazole, antacid, pantoprazole, BND. Which are the proton pump inhibitors here? Good, Hannah. So again, one more tip for you. B and D, prazoles, are proton pump inhibitor. Ranitidine is a histamine inhibitor. So that's a different route. So the tidins are different. All the prazoles are proton pump inhibitors. So I'm asking this question just to emphasize the point that there is some easy way to remember what is the action of different drugs and why it is being used. Nurses, if they keep their eyes and ears open and start speaking to the doctor, you will get free education every day. So, what do you think was Mrs. Menon's adverse drug event? Why did she get dark stools? Blood loss due to aspirin, blood loss due to prolonged intake of NSAID with aspirin, side effects of simvastatin and aspirin, all of the above. Okay. Quick finger, Hannah, you're in action. Very good. Blood loss due to prolonged intake of NSAID with aspirin. The doctor did say to stop the aspirin, but she continued to take. So that was the problem here. So the next question is, what could be the reason for patient not returning after 1 week as instructed? Why she did not return after 1 week? Had inadequate patient family education and lack of teach back. Lack of doctor education, lack of nurse education. Patient must not have been listening. What do you think could be the right answer here? So I would put it as it was probably an OPD, whether it is a doctor or a nurse. It just simply shows the family and the patient was not educated, and most importantly, lack of teach back. Many times we are teaching patients, but we do not get them to teach back. That is another communication tool that we discussed. Very powerful. Even today, when as you are listening to me, if I ask you people to teach me back, probably the learning will be far more powerful. 19. Doctor has ordered 3 units of insulin IV per hour. You have 100 units per ml of insulin for preparation. How will you admixture insulin drip in 50 ml syringe? 50 units in 50 ml of saline. 100 units to be mixed with 49 ml of saline. 1 ml of insulin in 50 ml saline. Any of the above will do. What could be the answer here? Good, Hannah. So they are, you might think, this is not making much of a difference. It makes a lot of difference when you actually mix. 1 ml needs to get into 49 ml of saline. You don't make it 50 plus 1 ml, 51 ml, because the entire maths and the dose will change. Okay, so you have 100 units per ml, so you are taking 1 ml, you add it to 49 ml. So let me ask you, how many units per ml then it will be finally when you mix it up? How many units per ml? How many units per ml? Okay, 2 units per ml. Hannah has already given answer. So let's see what will be the flow rate. The order is to give 3 units of insulin IV per hour. So what will be your drip rate in syringe pump? What will be the answer? One 1.5 ml per hour, because we already said that you have to give 3 units. So per ml is 1 unit. So obviously it is 1.5 ml per hour. Now we have finished with medication safety. So let me tell you again, I want to emphasize, this is not the beginning and the end of the domain that we are discussing. I have only discussed the most common areas of errors that I have experienced in my lifetime. I put those questions together. There are many more things that could go wrong. As you work in the hospital, keep your eyes and ears open. Try to learn from others' mistakes so that you don't get into making that mistake. It should be not only individual, the units, the hospital, the newspaper. When you see something, it's best to learn from those mistakes. Now we come to alarm safety. Now this is a new domain. So I included this here so that more and more patients are in the ICU. Now this is very important to know. Too many alarms in the ICU. 187 alarms per day, 88.8% are false alarm. So what happens because of not attending to alarm? 216 deaths. One alarm every 90 seconds. So I'm an ICU nurse. So I understand. So what is happening? Throughout the day, you are only hearing alarm. So I used to have this, something like tinnitus when I was in the ICU. Every time I'll be hearing tung, tung, tung. Even when I'm sleeping, I used to hear that. Too many alarms. So how do you ensure that you are not getting into alarms fatigue? So this is a new terminology. So what is alarms fatigue? So I'm going to go through this slightly faster. I am aware of the timing. So here the answer is sensory overload when exposed to excessive number of alarms. So it is almost like that story, that you know there is the lion came. The shepherd keeps shouting every day when he's bored that tiger is coming, tiger is coming. And when villagers come, nothing is happening. When that happened, nobody came. Okay, this is a common story all of us must have heard. Similarly, when you have too many alarms running all the time, we tend to get sensory overload and we may not pay attention to the alarms. So this used to be a problem. Doctors used to complain to me, "Ki, ma'am, please talk to your ICU nurses. Why do they go and silence the alarm without looking at what is happening?" Because people are used to it. They say, "Oh, ye to basta hi hai." I mean, it's anyway alarming, so why should I bother? So few of the outcomes of alarm fatigue. What can happen when you are you know what is alarm fatigue? Sensory overload. When that happens, what could be the outcome? Ignoring alarms, setting up limits, actively silencing alarms, adjusting the limits. A and C. Now answer is A and C, because setting up limits is a good habit, adjusting the limit is a good habit. Because of sensory overload, you may end up ignoring the alarm or actively silencing without paying any attention to why the alarm is coming. Next is the monitor usually gives two types of warning sounds. Most of the monitors, they give two types. Even by sound also they are different. What are the two types? Alerts and alarms, high and low, critical and non-critical, any of the above. The answer here is they are categorized into alerts and alarms, and high alert and low alert. Critical and non-critical alarms can come up. So each company, the monitor or the ventilator, they will have different types of alerts and alarms incorporated, built into it. It's very important for us to learn which are the alerts and alarms which are there in our machine and get used to this. You should know what is the sound, what is the different variations in the sound. Being an ICU nurse, I could tell from very far, that this is this kind of an alarm. So I will decide whether I am going to shout out and say, hey, alarm, or I will actually walk, or I will run and shout and say, hey, I am sure there is VTVF happening somewhere. I knew it. I could run. So it's very important, get used to it. Now you're caring for a patient in ICU. Intensivist enters the ICU and shouts at the nurse. The monitor is alarming. The heart rate is 180. What are the possible reasons for the nurse to overlook the alarm? Tick all that apply. Nurse is desensitized, insufficient monitoring skills, staffing challenges, equipment failure, all of them. One could be that the nurse is so used to the alarm that she's not even bothered, or she does not know how to monitor, or too many patients, too less nurses, so they are not able to attend, or the equipment itself has become faulty. So it doesn't matter what is the reason. As a nurse, as a ICU nurse, I'm supposed to attend to the alarm to figure out what is happening. Some basic actions critical care nurses can undertake for effective alarms management. Alarms management needs a SOP in place, needs a policy in place, it's a protocol in place, and it will differ from ICU to ICU. Admit and discharge patients from cardiac monitoring system, review alarm settings and customize, ensure proper placement of electrodes, silence the alarms. What could be the answer? Standardizing alarms policy for each unit. So this is accept. So silencing the alarm is definitely not alarms management. So these are some good practices to have. Admit and discharge patients, because on the monitor usually you enter and say so and so patient's name also reflects. So that patient's history will be kept in the monitor. So it is better to discharge the patient from the monitor so that the next patient is taken as a new setup. Otherwise, it will take the old patient settings. Now, it is a good practice that in every shift, the nurses should be looking at the alarm settings, and they are allowed to customize the alarms based on the guidelines which is laid out in the policy. And proper placement of electrodes should be always maintained so that you can avoid any unnecessary alarms because of the electrode not being placed properly. So let's look at the next one. Artifacts that lead to false alarms can be due to artifacts. Artifacts are those, irregular lines that come up in the ECG monitor especially, and it can sometimes lead to false alarms. How can that happen? Is it because of lead placement, electrodes movement, patient motion, lack of proper grounding, or is it all of the above? It is all of them. If you don't place the lead properly, it can lead to unnecessary alarms. Electrodes might be loose, so they may be moving, or patient himself could be moving, or the proper grounding of the machine has not happened. Even that can lead to artifacts. I am sure you must have seen ECG machines giving artifacts because they are not grounded well. Select the clinical alarms from the following. This I would like you people to pay attention and select the answer. Electrodes disconnected, ventricular fibrillation, SpO2 less than 80, faulty saturation probe. Out of these, which are the clinical alarms? Can I get some answers in the chat box? Waiting. Hannah Oswin. Quick finger. Thank you. Pamela says B. No name, Galaxy A30, B and C. Okay. B. Okay. B and C. All right. So you're somewhere there. I'm sure that nobody picked up, electrode and faulty saturation probe. They are hardware, right? We are asking for clinical alarms. Even though those will alarm, even that will give you alert. The electrode is disconnected. The saturation probe could be wrong. So the answer is B and C. Ventricular fibrillation, SpO2 less than 80, are the clinical alarms that can happen when you are monitoring. Okay, now we come to the last segment of blood transfusion safety. Now, this is a very important component for nurses. Apart from medication, this is also very important. This can lead to patient harm. So, we are going to go through this also quickly. The non-cellular component of blood is, now this is a very GAN question. I'm sure that many of you will get this very right in one go itself. Plasma. Rest are all cells. Okay. Now this is just to kind of understand that when you're getting into transfusions, you understand the blood a little bit. The clotting factors made from plasma is known as, so the most concentrated clotting factors which are made from blood are known as cryoprecipitates. Fibrinogen is a protein which helps in clotting but is not clotting factor. Platelets also help. In the clotting triad, you will find all of them, but the factors made from plasma, they are known as cryoprecipitate. The doctor order states transfuse 1 unit of blood. What would the nurse do now? Send cross-match sample and blood request. Inform doctor, ask for a complete order. Inform the ward in charge. Ask the doctor to fill the blood requisition form. Now, maybe many of them are looking very correct, but I would always say inform the doctor, ask for a complete order. This is very important. 1 unit of what? Whole blood, packed RBCs, and whether that 1 unit in some hospital it is required, how many ml is to be written also. So 1 unit could be 350, could be 280. So the volume, and it also needs to be written that whole blood or packed RBCs and over how many hours. This is very important. Transfuse 1 unit of intravenous over how many hours. So it is always good to ask the doctor for a complete order. You may do the rest of the things. You will have to send, the doctor has to fill the form and you have to send the cross match. All these things will happen. But most important, learn to ask for complete orders. While taking blood sample for cross match, the following have to be followed strictly to prevent blood transfusion errors. Ensure that the patient is identified by comparing name and UHID in file with that of patient ID band. Ask the patient to state his or her name. Label sample after collection at the bedside. Label the collection tube at station where barcode is printed. All of the above. So I am trying to see, by this time everybody should be getting the right answer, because we have discussed about this in different aspects. So I'm looking for some answers. Why someone selected D? You got one more option now, all except D. Yes, all except D, because we already said that you will not label. You even when you print a barcode, you will take it to the bedside, and then after that only you will apply it at the bedside. So you have to do all the things correct, and it has to be done at the bedside. Involve the patient also. Very important. Good. Very good. Many people got the answer correct, or some. So when blood bag is brought to the unit, the following are to be kept in mind before starting the transfusion, except you have to pick up the wrong answer. Let's see. The blood should not stay longer than 30 minutes in the unit. There is an anticipated delay. Return the blood bag to blood bank. If there is an anticipated delay, keep the blood bag in the unit refrigerator. Make sure that the blood is warmed before transfusion. So what will be your answer? What is the except here? Which is not the correct answer. Okay. Some of you got it correct. Very good. If there is an anticipated delay, keep the blood bag in the unit refrigerator. Is a no, no, no. You cannot keep it in the unit refrigerator. It is not designed to keep the blood. So in case the blood has come and because of some reason you know that it is not to be given, you should make sure that you return it to the blood bank and tell them that you will get it again. So there has to be a policy around it. You cannot keep it in the refrigerator. This is very important. Okay, let's go to the next question. The blood bank needs to be called 40 minutes prior to collecting the following blood products. Tick all that is correct. Which are the, Elizabeth is telling can't return also, so that you need to discuss in your own organization to find out what is the best policy that can be drawn up. But keeping in the fridge is definitely not the answer. The blood bank needs to be called 40 minutes prior to collecting the following blood products, which could be the products. Any quick answers from anyone? So if you know which are the frozen ones, then you will know they are the ones you have to inform early. So cryoprecipitate and fresh frozen plasma, both. Okay. So if you are giving them, you have to call the blood bank 40 minutes early. And why are we calling them is the next question. Why are we calling 40 minutes early? The product needs to be warmed up, the product needs to be thawed, the blood collection needs to be done, all of the above. The process is called the product needs to be thawed. They have to bring it out of the refrigerator, and yeah, they have to make sure that it is no more frozen before they release it. Okay. So these are some basic information that we should know when we are managing blood and blood products. The one product that should not be mixed with blood, as it will lyse the blood, because you will be using various types of infusions around the blood. So which one you should never ever mix it up? Any answers? I'm going to go quickly. It is albumin, because it will lyse the blood. So okay. All right, where should the final double checking of blood be done before initiating the transfusion? So now this is a very, very important practice that you all must learn, so that you are not doing the wrong procedure and then somewhere you also get into trouble. The doctor needs to match the cross slip and blood bag and write it down in the patient file. The nurse, before starting, matches the information on the blood bag with that of ID band and UHID. Two nurses or one nurse and a doctor must check the details on the cross-match slip with blood bag, file, patient ID band, name, and UHID. Ask the patient to state her or his name. Tick all the correct actions. Verify that the blood transfusion consent is taken and the patient is educated about the procedure. Where should the final double checking of blood should happen? That is the question. Ensure that blood type, unit number are matched between blood bag and cross match slip. So what is the best answer which is available here? So please remember that it is two people at the bedside based on your hospital policy should be checking the information on the blood bag, cross match slip and the patient file. Identify the patient, make sure the consent is taken, patient is aware of the procedure, ensure blood type, unit number are all matched across blood bag and cross match slip. So you are having patient file, you have the cross match slip and you have the unit of blood or blood product, and you two people have to ensure you have the order written down, you have the consent and everything else is matching, the bag number, the cross match number, patient name, UHID. Take time to do this. Do not go to the nursing station and give the bag to the doctor and say, "Ki, please, write it down that you have verified this." That has got no meaning. The verification has to be at the bedside. Very, very important. Please remember this and learn this very good today. In order to ensure the transfusion is safe for the patient, what will the nurse do? Tick all that apply. Make the initial run rate very slow for the first 15 minutes. Pre-transfusion vital signs are obtained. Stay with the patient for the first 15 minutes observing the patient. Pre-medicate if there is doctor's order. Complete the transfusion in 4 hours. Oh, I got the answer also correct. Tick all that apply. You should have ticked all of it. This is very, very important that you run the blood slow, watch the patient, whether the patient is having any adverse reactions. Before that, vital signs are all obtained. Pre-medicate if there is order. And after that, ensure that the transfusion is completed in 4 hours. Whatever the doctor has written, it doesn't matter. It should not be hung for more than 4 hours. These are some basic things that you follow for your entire life whenever you are handling blood. Now you're on night shift and the patient assigned had been ordered 1 unit of PRBC. Following all the set protocols, after double checking, you start the blood transfusion. Within 10 minutes of starting the transfusion, the patient complains of chills and flank pain. You observe that the patient is also having breathing difficulty. What will be your immediate action? Select the wrong actions. Stop the transfusion, start saline. Stop the blood, aspirate 3 to 5 ml of blood from the IV cannula, flush the cannula and keep the vein open with saline. Stop the blood and remove the cannula. Check the vital signs including assessment of breath sounds. Collect blood and urine sample. So select the wrong answers. So let me see if you have selected the wrong answers. Inform doctor and anticipate administering hydrocortisone and Avil. So what will be the wrong answers here? A and B. A and B. Okay. Let's see. Reassure the patient. There's one more option. Reassure the patient and stay with the patient. Wrong answers does not change, I guess. Stop transfusion, start saline. Now I'm going to explain to you why. Stop the blood and remove the cannula. You have to keep the vein open because in case of an emergency, you need IV access. So the best one is to stop the blood, aspirate 3 to 5 ml of blood, which you can remove, and flush the cannula. But this has to be as per your hospital protocol. But the best practices, this is what is mentioned that you should do. Check vital signs, including assessment of breath sounds. Collect blood and urine samples. Inform the doctor. You anticipate that he would give hydrocortisone and Avil. The patient is complaining of chills and flank pain. Stay with the patient. This is very important. Do not leave the patient. So next question is related to this. As the above patient is complaining of flank pain, what other observation will you include? Look for rashes, watch for urine output and urine color, check for blood sugar, start oxygen. What do you think is the right answer here? Because patient has got flank pain. Flank pain. So flank pain is the pain in the area of the kidney. So watch urine output and urine color. So it could be microembolism happening. So this is one of the some adverse effect that can happen because there is small blood clots that can block the um, renal. So you could have kidney damage, so you want to ensure that you look for the urine output and the urine color. When patient is complaining of breathlessness, so obviously you'll start oxygen to prop up, you will do all that stuff that is required to be done. Since your patient is also having difficulty in breathing, ouch, I asked gave some answer away, I guess. What are you going to do for this patient? He's also complaining of breathing difficulty. Select the wrong answer. Prop up the patient, check saturation, check airway patency every 5 minutes. Stay with the patient as patient can deteriorate very fast. Administer the ordered medicines and come back to check every 5 minutes. Ouch. The answer also came. Okay, Hannah, quick finger, very good. You already picked up the right answer, D. So you cannot leave the patient alone. Stay with the patient, prop up the patient, check saturation, check airway patency every 5 minutes. They can have laryngeal edema because of the antigen in the blood product that is gone in is like a antigen. So patient can have allergic reaction. So stay with the patient. Patient can deteriorate very fast. Now, this is where the critical thinking skills of every nurse come into play when something goes wrong with the patient. You're able to pick up the right things and do the right actions at the right time. So, after discontinuing the blood due to reaction, where will you discard the blood bag and the blood set? Throw in the red bag, send both set and bag to blood bank along with samples. Keep it in the unit, throw when the blood bank informs you to do so. None of the above. What could be the answer here? Yes. Send both set and bag to blood bank along with samples. Okay, thank you. Manjumol started giving the answer first. Okay, great. Thank you. Yes, you will send all of them to the blood bank. So I think we have come to the end of the session and it's exactly 1:10. We started a little late. So what next? So now that you have spent time, I am happy that we still have 143 people in the session willing to learn and understand. So as I told you, do not get left behind. You can tell your friends. In 48 hours time, we will upload this video on the website www.cygniahealthcareacademy.com, and this will be available as a free course, and you can go in. If you want to watch the video again, you can watch the video again. After that, you will give a quiz of 50 questions. And when you get 80 percentage marks, you will automatically get a certificate. You can download it from the site itself. You have to create an account. Okay, and while you are there, you can also explore other courses which are available on the site. This is totally a e-learning portal, so you can study at your own pace and go through it, and you can let us know also if you think there are some pertinent courses that we should put up. We would love to hear from all of you, so please write to us. You can write to this email ID, or you can WhatsApp on this number 9871798914. So thank you very much for to all of you. So I will now stop the recording.